Dr Athmaja Thottungal, thank you so much for joining us for this brief 5-minute interview about RUK 21. How are you?
I'm good. Thank you, Amit. So lovely to see you today after such a long time, even if it is virtual. I'm really
Absolutely.
pleased to be here.
And it's really lovely to see. A lot of people won't necessarily realize that we did our training together. And in fact, we started off many of our first meetings together as part of LSORA, the London Society of Regional Anesthesia. So it's lovely to see you here in this format and in this guise. Um, so first of all, I wanted to say there are very few people who possess, in my opinion, the amount of knowledge and experience you have with regards to anatomy, ultrasound anatomy, scanning, regional anesthesia, and that beautiful transition between chronic pain. So I'm really excited to have you as part of our meeting this year. What I'd love to
Well,
ask you,
thank you so much, Amit.
what I'd love to ask you first is, what are you looking forward to about RUK 21 this year?
For me, it is like coming back home again because you guys, we trained together, we learned together, and I started my ultrasound training as a regional anesthetist first before I translated that skills into pain medicine. So it is really a very good opportunity for me to see what is happening in the regional anesthesia world because that is what I always do. I learn new exciting things in regional anesthesia, then translate that into chronic pain. And I can, of course, bring back something from chronic pain back into the regional anesthesia as well. And this year, it is all started with wonderful lecturers from all over the world. They are all very well known faculty, and it will be a wonderful meeting. So I'm really excited and looking forward to it.
And why do you think we need to encourage our potential registrants to join the meeting? What is it you think they're going to get out of it?
I mean, the COVID does not stop our patient care. We need to update our skills, our knowledge, and then move on. And I feel in this era of COVID, the regional anesthesia skills are even more important because we try to avoid airway manipulation as much as possible. So it's not like a quickly having an airway or a general anesthesia. If you have the skills of regional anesthesia, that will give you that extra skill mixture to look after your patients better. And we are looking into all sorts of chronic pain problems as well. So the regional anesthesia is gaining more momentum as a supportive measure to prevent that chronic pain development as well. So I feel it's more important to get into regional anesthesia, get your skills up, and be a very good regional anesthetist.
I think that's brilliant. Thank you, Othman. We're really looking at people like you to act as amazing role models for regional anaesthetists and chronic pain physicians of the future, and even tying the specialties together in translational pain and bridging that gap between acute and chronic pain. So, for me, it's very exciting to have you as part of the meeting. And I've been asking all of our people that have been partaking in our 5-minute interviews 3 questions, which hopefully won't come as much as a surprise to you. So if you had to pick your favorite upper limb, lower limb, and trunk block, I'm really interested to hear what you have to say.
Because I wear these two hats, both regional anesthesia for acute pain and chronic pain, it's completely different mix for each context. So if I have to choose in an acute pain context, I would say superior trunk is my favorite for the shoulder in acute pain as well as chronic pain. But in chronic pain, I do use the dorsoscapular nerve a lot as well for the shoulder pain. So those are the two favorite upper limb ones for me. And probably you know, Amit, I do a lot of work on the superior trunk neuromodulation for the chronic pain patients. So that is my favorite in the upper limb section. In the lower limb section, probably I do most of them popliteal as well as the sciatic at the supragluteal level because this is for amputation, above knee amputation in our hospital. We are a couple of consultant who does complete awake above knee amputation just under block. So that is one of the things because I do a lot of pudental in chronic pain. So the gluteal region scanning and identifying the sciatic and the nerves there is both acute and chronic pain is one of my lower limb favorites. In the abdomen thorax region, Thorax region, I would say probably pec block is my favorite because I do a lot of post-surgical breast pain patients, and it is one of the things probably pain world should embrace a bit more, especially the post-surgical pain and post-chemotherapy pain, widespread pain in the pec region. And abdomen is genitofemoral nerve because it's
Wow.
again a new technique which I use a lot, and it is something that people are not very familiar with, the genitofemoral nerve, which is very easy to block actually. As a, just similar to ilioinguinal block, it is very easy to block in acute as well as chronic pain.
Well,
So
this
that
is
would be my.
something I'd love to see. I'm hoping we're going to get a chance to see you demonstrating some of these techniques. This sounds fabulous. The last thing I want to do, these are some really fascinating insights you've given us. I want to pick up on the awake amputation. So tell us a little bit about your recipe for your amputation. So if you're going to do a below an awake above knee, sorry, an awake above knee, what's your recipe?
Okay. So below knee, as you know, popliteal sciatic covers almost 95% of the area. So it's not at all a difficult thing to do. You just need the saphenous just above the knee and the popliteal. That's done for you. Above knee, you need to remember you need to block five nerves. Three nerves anteriorly, two nerves posteriorly. Okay, so the anterior ones are your femoral, obturator, and the lateral femoral cutaneous, which you can access in two ways. And the popliteal, which is the sciatic, is not enough for you for that. So you need to go at the just below the piriformis, which is like the gluteal level, because you need to block your posterior cutaneous nerve of thigh as well, which is a big part of your dermatomal distribution in the posterior thigh. So I normally do the patient's side in the top of the, like, on the lateral side with the operating side up. I go for the lumbar plexus block, which is like the anterior approach. So on the front of your swas, you can see that with your conventional quadratus lumborum block approach. So you will be able to block your obturator, your femoral, and the lateral femoral cutaneous there. The other way to reach that is the conventional facial iliaca block, but the suprainguinal approach with a high volume. But I prefer to go through the lumbar area so that you are only blocking the anterior part of your lumbar plexus, and three will be covered there. Then the same position, you can scan your gluteal region for your sciatic nerve as well. So the upper lumbar region, you cover your femoral obturator, lateral femoral cutaneous. The lower lumbar will be covered along with your sacral region in the sciatic, high sciatic block, and your posterior cutaneous nerve of thigh is also done. Now, one thing I want to stress, these patients are chronic pain patients. So they feel some discomfort at 3 points. One, cutting the bone. The vibration sensation patient might feel as pain. The second one is if they are using cautery, the temperature can be perceived as discomfort. So I tend to give them a tiny bit of ketamine if it is not contraindicated, like a 15, 20 milligram, maximum 25 milligram ketamine, because it works on the dorsal root ganglion. So that will cover your sympathetically mediated pain, which is going through the dorsal root ganglion as well. So that is my recipe.
Fantastic. Athma, what an amazing insight into that incredible brain that you have. And I really look forward to learning more about that when we see you at REK 21. Thank you for taking the time to join us, and we'll see you soon. Take care.
Thank you. Thank you for having me, Amit. Lovely to see you.
Bye bye.
Bye bye.